Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we are performing left laparoscopic nephrectomy for a non-functioning kidney which was hydronephrotic and was pyonephrotic secondary to stone disease, and we put in a percutaneous nephrostomy which remained there for around 3 to 4 weeks, and now we have planned to go for a laparoscopic nephrectomy in her. So we are discussing the port placement here. We are not using a routine port placement which is baseball diamond or a circular technique. First of all, we have to see the landmarks here. Here you can see this is the costal margin and this is the tip of the 9th rib here. So most probably this is our target area for the renal hilum. So at the tip of the 9th rib we will put in the optical port, 1 finger breadth below the costal margin or the 9th rib, the tip of the 9th rib. So the second port, which is working port, will be a 10 millimeter port, and this will be 7 centimeter below the optical port. So it comes out to be here. And the third port will be 7 centimeter from the optical port and 10 centimeter from the other working port. So this will make a triangle. And at times we also put in another assistant port, so we make another triangle. The third port or the fourth port, the supportive or the assistant port, comes here. So we create pneumoperitoneum through this port, and then we put in a assistant port which will help us lifting the kidney for retraction. And second thing is that we can use a suction here, and by the end of the procedure we will put in a drain here. So this will be another triangle of the same size. So now we create the pneumoperitoneum. Always remember that the final port placement is decided after the pneumoperitoneum is created, because all the landmarks, they change. They change after creation of pneumoperitoneum. The skin will be stretched and this will come here. So do not decide the port placement before creation of the pneumoperitoneum. So we check the patency of the needle. Yes, तैयार रहेगा ना. 1 click, 2 clicks and 3rd click, and now we will see whether this is in the peritoneum. We put in saline and then aspirate it. It is not coming, so most probably we are in the cavity. And then we do the hanging drop test, so which is going smoothly into the peritoneal cavity. And then we attach the gas. And always remember, when 200 ml of gas goes into the peritoneal cavity, the spleen dullness is gone. So this also shows that we are in the right space. So we look for the pressure to develop. When the intraperitoneal pressure becomes 12 millimeter, and then we say that the insufflation is complete, and then we put in the ports. So there is symmetrical distension of the abdomen. So we are in the right space. As I said earlier, the landmarks change. Now you can see that the landmarks have changed. The skin which was here before the pneumoperitoneum has moved here. So if we put in ports before or decide the port placement before the pneumoperitoneum, all the anatomy will change and the procedure will become difficult. So the pressure is now around 12 millimeter of mercury, and now this becomes the tip of the Rhine rib, and this is one figure bed. So we will put in the optical port here. We make a incision in the skin, and this is usually the 10 millimeter port. White balance some kade.
Yes.
So we are in the peritoneal cavity. We can see the spleen, the diaphragm, the left colon, and this is the gut. And we see the place of the varus needle to see if there is any complication. So it is free of complications. So the second port will be 7 centimeter below and lateral to the optical port. So it comes out to be here. ये बाने फोकस करो आगा सिम वीडियो के राजी का ना पोर्ट and another working port will be 10 centimeter and then 7 centimeter, so it will make a perfect triangle here. So you see here the ports now are 10 centimeter, 7 centimeter and 7 centimeter. And that's it, huh? Thank you.